support injuries around the knee. The intended learning outcome is to provide a quick overview on the ligamentous structure supporting the knee, the common mechanism of injuries, how to diagnose the different imaging modalities, and the different treatment options. First, the anterior cruciate ligament, or the ACL. It's attached to the tibia anteriorly, and that's why it's called anterior cruciate ligament, and it's attached to the femur posteriorly, to the laterofemoral condyle specifically. It's formed of two bundles, the anteromedial bundle and the posterolateral bundle. That's an arthroscopic view of the ACL ligament. It's the main restraint to anterior tibial translation and to knee internal rotation, and a second restraint to valgus and varus forces. In addition, it contributes to knee proprioception. The PCL, or the posterior cruciate ligament, it is attached to the tibia posteriorly, that's why it's called the posterior cruciate ligament, and it's attached to the femur, medial femoral condyle, anteriorly. It's a very strong ligament, and it's formed of two bundles, the anterolateral bundle and the posteromedial bundle. It's the main restraint to posterior tibial translation, and a second restraint to varus and valgus forces, torsional forces, and contribute to knee proprioception. Medially, the knee is supported by the MCL, or the medial collateral ligament, and it's formed of two parts, the superficial part and a deep part. The MCL is the main restraint to valgus forces around the knee. That's a cadaveric dissection showing how the MCL looks like. The lateral aspect is supported by a complex structure called the posterolateral corner. The LCL is one of that structures and stands for the lateral collateral ligament. It's the primary restraint to varus forces. Inside the knee, there are two C-shaped cartilage formed of fibrocartilage, and they are called menisci, the medial meniscus and the lateral meniscus. They contribute to articular congruity, reduce contact stresses, act as the shock absorbent, contribute to knee stability, and contribute to knee proprioception. And that's why when they are injured during surgical treatment, we try as much as possible to conserve them. The common mechanism of injuries are motor car accident leading to a dashboard injury, a direct hyperextension forces, fall on a flexed knee, and if that happens specifically when the foot is plantar flexed, it can lead to isolated PCL injury or a direct blow to the knee, whether to the front or to the sides. From the direction of force, you can imagine where are the structures that can be torn. For instance, a direct blow to the medial aspect of the knee probably will lead to injury to the lateral structures of the knee, in addition to the ACL. That's very unlikely to lead to injury to the medial structure of the knee. Diagnosis follows history and examination, supplemented by investigations. But there are certain key questions you have to look for during history taking. If there's a traumatic event and it is a non-contacted trauma with a clear pop, you can think of an anterior cruciate ligament rupture or a patellar dislocation. If it follows a contacted trauma and there's a clear pop, it may be due to fracture, meniscal injury, or any other associated ligamentous injury. Ask about the ability to walk after the injury. If the patient is able to walk or even to continue the sports activities, you may think of meniscal injury, or less likely a posterior cruciate ligament injury. But if the patient is not able to wear to continue what he was doing, we consider a more serious injury. Could be a fracture or could be a ligamentous injury, like anterior cruciate ligament injury. Ask about the swelling. If there's any swelling immediately after the history of trauma, you may consider a serious injury, like a fracture or a ligamentous injury. But if the swelling is late, you may consider a meniscal injury. Locking. If there's a loose body inside the knee that can be trapped between the femoral condyles and the tibia, preventing the knee from fully extension, or there's a loose meniscal fragment, the patient would complain of locking. Sense of giving way or instability may follows ligamentous injury or patellar instability. Clinical examination, general examination, and a local examination to the knee. You have to compare both knees together. On an inspection, you have to look for swellings, bruisings, wounds, any virus or valgus malalignment, range of motion, gait abnormality, and you have to palpate for the point of tenderness. Quadriceps wasting may indicate a long-standing problem. There are special tests for the ligamentous structure supporting the knee. The ACL can be tested by anterior drawer test or Lachman's test. The PCL can be tested by the posterior tibial sag on looking to the knee from the lateral aspect, posterior drawer test, and quadriceps active test. The collaterals can be tested by a various valgus stress testing in a full extension and in a 30-degree flexion. Meniscal injuries can be suspected using McMorris test or Apley compression distraction test. At last, neurovascular examination is very important. A multiligamentous knee injury may be associated with injury to the common peroneal nerve, or more seriously associated with acute ischemia. X-rays, AP view and lateral view. You have to look for fractures or even dislocations. Sometimes the ligaments are not torn intersubstantially, but they are avulsed. This X-ray shows how an ACL is avulsed from its tibial attachment. MRI is more accurate in diagnosing meniscal injuries and ligamentous injury as well, in addition to osteochondral injuries. That's an MRI showing a torn ACL. That's an MRI showing a torn PCL. It's clear that the tibia is translated posteriorly in addition to the torn PCL. That's a coronal cut showing torn lateral collateral ligament. That's an MRI showing osteochondral lesion in addition to injury to the MCL. Meniscal injuries can be detected at the signal intensity inside the substance of the meniscus. At that example, the treatment options, generally speaking, they can be managed operatively and non-operatively. Isolated injuries, isolated ACL injury. The ACL has no potential for spontaneous healing. If there is a tibial avulsion, we may consider doing surgical fixation for that bony avulsion. Traditionally, we used to do during open surgery approach. but recently it can be done using arthroscopy. If there's a mid-substance tear, and since there's no potential for healing, the standard is to do an ACL reconstruction. On the other hand, regarding isolated PCL injuries, the PCL has a high potential for healing. Again, if it's a bony avulsion and it's misplaced, we consider fixing it surgically. But if it's intrasubstance tear, we may consider non-operative treatment depending on its power of healing. And if it's a completely torn with a gross instability and associated with other ligaments, we may consider doing surgical reconstruction. Regarding the isolated MCL injuries, MCL has a very high power of healing. That's why most of MCL injuries are managed without doing surgery. However, grossly unstable MCL injuries, grade 3 injuries, especially if they are associated with other ligamentous injury, we may consider doing surgery, whether it's surgical repair at the early stage or doing a reconstruction later. On the contrary, the lateral collateral ligament power of healing is very limited. That's why, apart from grade 1 mild injuries, grade 2 or 3 injuries, or injuries associated with other ligamentous structure, we may consider doing a surgical reconstruction for the lateral collateral ligament. The treatment strategy for multi-ligamentous knee injury is a very complex topic with a very different surgical protocols. And there's a huge debate what to do and how to do and when to do those kind of injuries. For example, if there's an ACL torn in addition to collateral ligaments, we may consider doing a non-operative treatment first for the collateral to heal and then restore the knee range of motion. And later on, reconstruct the ACL. If there's a PCL torn in addition to the collaterals, in addition to an ACL as well, we may consider doing a PCL first to reduce the knee joint, and then regarding the collaterals, we may consider doing surgical treatment as well. For combined ACL and PCL injuries, again, we may consider doing a PCL reconstruction or surgical repair and then doing an ACL reconstruction later on. Others may consider doing ACL and PCL at the same session. The bottom line, management of a multi-ligamentous knee injury is a complex structure with different surgical protocols. Regarding the meniscal injuries, when we deal with the degenerative tears not reaching the articular surface without history of locking, especially in old patients, we may consider non-operative treatment. However, acute traumatic tears, especially in younger patients and in patients with a long-standing tear that's not responding to non-medical treatment, we may consider surgical intervention. The treatment options include partial meniscectomy or meniscal repair. We try as much as possible to conserve the meniscal tissue because of its importance in protecting the knee joint from developing osteoarthritis. That's an example of a degenerated tear of a meniscus, which was managed by partial meniscectomy using arthroscopy. Again, if we can repair the tear and conserve the meniscus, we prefer to do so, but there are certain prerequisites for the surgical repair. And there are different surgical techniques to do that. Now, the standard is to do it arthroscopically. Whereas that's an example of an inside-out technique. Recently, we can use specialized meniscal sutures that can allow us to do the surgery and repair the meniscus using arthroscopy without doing any surgical incisions or open surgical approaches. In summary, knee sports are very common injuries. MCL ligament is the most commonly injured ligament. Unfortunately, it is commonly managed non-operatively unless it is a grade 3 injury and associated with other ligamentous structures injured as well. History and examination investigations are mandatory for diagnosis. MRI is a gold standard, but you cannot depend on MRI alone. You have to take history and examination before doing an MRI. ACL and LCL have poor potential for healing, in contrary to the PCL and the MCL. And that's why when dealing with an ACL or LCL intersubstance tear, we prefer to perform reconstruction. On the other hand, a PCL and MCL injury, there's a role for a non-operative treatment. Thank you.